Hello, everybody, and welcome to February's edition of the St. John's Cancer Institute's Be Inspired Speakers Series, Understanding the Cardiac Effects of Cancer Treatment. My name is Jean Goldsmith. I am a Development Director at St. John's Health Center Foundation. St. John's Cancer Institute, our name as of January 2021, probably sounds new to you, as you have known us as the John Wayne Cancer Institute for many years. At the end of 2020, the licensing agreement between allowing Providence St. John's to use the name and likeliness of John Wayne on the Institute and the fellowship program expired. Going forward, the Institute will now be known as St. John's Cancer Institute. The change is in name only. It will not impact the Institute's operations in any way. And we're also very excited to announce that the fellowship program will carry the name of the surgical oncologist who founded the Institute, Donald L. Morton. And the name of the fellowship program is the Donald L. Morton, MD, Complex Surgical Oncology Fellowship Program. St. John's Cancer Institute will continue to provide excellence in research, education, and cancer care through innovative clinical trials and research, and the education of the next generation of surgical oncologists and scientists. And of course, state-of-the-art treatment for our patients. Going forward, we will expand and deepen the focus of our main pillars of cancer research: immunotherapy, genomics, and precision medicine. So before we get started today, I just wanted to let you know that we are having some technical difficulties at St. John's, unfortunately. So you may be hearing my voice a little later than I am speaking. So just, it's not you, it's us, and we hope that everything should be fine. So we'll just continue on as if there's no problems here. Before we get started, I'd also like to give you some information to help you ask questions of our speakers. As you notice, everybody but the speaker is muted so that we'll all be able to hear the speaker very well. In order to ask questions, which we hope that you will do, we ask that you use the chat function, which is at the bottom of your screen. The chat function looks like a little thought bubble, and when you can type into that chat function and we will see your questions. And when we start answering the audience's questions, we'll read them from that chat function side. So thank you for typing your questions into that. If you don't hear us answer your question, I will then send an email after the fact to you, because we have your email address, as that's how we got in touch with you initially. And if you have questions after the webinar, please don't hesitate to send an email to the same email that's contacting you, and we will get back to you with your answers. We have a very interesting hour in front of us as we learn about our work in cancer treatment and research. We will briefly hear how the Cancer Institute pivoted to support research and treatment in COVID during the COVID crisis, and that's work that is still going on. And we will discuss the cardiac effects of cancer treatments and what we can do to minimize the chances of having these issues. You've received information on our speakers, so I'll let you read their bio. I'm very honored to introduce the panel, who are physicians focused on medical oncology, cardiology, and radiation oncology. Our first speaker, or I shouldn't say first because it's a panel, but one of our speakers is Dr. Carol Nishikubu. She's a hematology oncology specialist with Providence St. John's Health Clinic. She has special interest in breast, lung, gastrointestinal, and hematologic malignancies. Dr. Nishikubu is also the vice president of the medical staff at St. John's Health Center. Dr. Nicole Weinberg is a preventive and imaging cardiologist with Pacific Heart Institute. She lectures on preventive heart disease, as well as women's heart disease, and is a driving force in the Women's Heart Center at Pacific Heart Institute. And Dr. Robert Wollman is a radiation oncologist and the medical director of radiation oncology at St. John's Health Center. His areas of expertise include advanced radiation techniques, such as partial breast irradiation, stereotactic radiosurgery and radiotherapy, and IMRT for many types of cancer. And moderating today is Dr. Neil Martin, the Interim Executive Director of the St. John's Cancer Institute. Dr. Martin is a neurosurgeon and is also the Regional Medical Director of Neuroscience for Providence, Southern California. He oversees neurosciences for the Providence hospitals and clinics across all of Southern California. Dr. Martin? Dr. Martin, I think you're mute. You're still on mute.
Right. So good afternoon, everybody. It's great to have you join us for this hour of discussion around cardiac issues related to cancer therapy. We've got an all-star cast of experienced doctors who will be able to answer many of the questions that we've got around cardiac issues. You know, I've just started working with the Cancer Institute here at St. John's, and it's really a privilege because this is a nationally known cancer institute. It's got a great tradition of both innovation in cancer therapy and also in training surgical oncologists and cancer specialists. Traditionally, it has used some of the latest technologies to gain new insights into the molecular biology of cancer that helps us tailor specifically the treatment for individual patients and to gain new knowledge about the biological behavior of cancers so that we can participate in the development of the next generation of therapies. We're particularly excited to have a new device called the Nano string device. If you're technically oriented, I would encourage you to take a look at this. It's a fascinating device that allows you to determine the genetic makeup of cancer cells one cell at a time. Very unique technology. Now, this past year has been a unique year in so many different ways. And the most notable way in the medical environment has been related to the COVID pandemic. And it hasn't, you know, none of us have escaped contact with this. And the Cancer Institute is also involved because we've used our outstanding clinical research team to do a number of seminal studies of COVID, including studies on remdesivir, this innovative drug that seems to be an effective therapy for patients with COVID, and numerous other studies. The team here, you know, amazingly, without recruiting a whole new set of investigators, has continued cancer research and done a whole series of nationally recognized COVID studies that have really contributed to our using science to win against this devastating disease. So we're very proud of that work. And hopefully as the pandemic recedes this coming year, we'll be turning all of those talents fully again on the battle against cancer of so many different types. We deal with the whole array of organ system cancers in the Cancer Institute. We use innovative precision medicine. We use immuno-oncology, immune system manipulation to battle cancer, radiation therapy, and surgery, all together integrated in this one large team. So today we're going to talk a little bit about cardiac issues that are related to cancer treatment. You know, Dr. Nishikubo, given your experience, how big of an issue, how big of a problem are cardiac issues related to cancer therapy?
So it depends on the exact medication that's being used in terms of chemotherapy medications. And I think Dr. Wollman will probably speak a little bit to the effect of radiation. And again, that depends also on the field of the radiation. If you look at the different chemotherapy agents, I think on average, the ones that do affect the heart, the incidence is about between 5 and 10% approximately, depending on the specific drug. But it also depends on the patient also. It depends on whether that person has underlying heart issues, whether they have underlying coronary disease, congestive heart failure, or underlying arrhythmias. But overall, if you look on average, it's the incidence is about 5 to 10%. And often, often it's asymptomatic. So in other words, sometimes we'll see a change in the cardiac function, but it really won't. The person will not have symptoms from it. It'll be just picked up on tests that we're using to monitor them.
I think you're still muted, Dr. Martin.
So Dr. Weinberg, what are the specific potential cardiac effects that can occur in patients undergoing cancer treatment?
Well, so cancer treatments can hit the heart in a variety of different ways. Chemotherapies can cause problems with blood pressure changes and arrhythmia changes kind of in an acute sense. But ultimately, over time, there can be damage to the heart muscles such that you can end up with cardiomyopathies where the heart doesn't squeeze normally. Subsequently, valves can function poorly, and you can end up with issues relating to volume overload or congestive heart failure associated with that. There are also effects to the heart that we see from radiation, as it can kind of hit the heart in the crossfire of the treatment, and you can get some calcification associated with that and inflammation within not only the heart arteries and the valves, but also the heart muscle itself can experience some changes associated with that radiation therapy. The radiation therapy, we oftentimes don't see effects acutely. We generally see that over time, but some of the chemotherapy side effects we can see more acutely, as they're going on, and that's why our teams here at St. John's are always so vigilant.
Well, it's great to have you on the team. No doubt about it. Now, how does a cancer patient suspect they're having heart problems from cancer treatment?
So oftentimes when patients are undergoing their cancer treatments, they're obviously monitored very closely in different clinical settings. They'll have their heart rate and their blood pressure checked very regularly. They're examined to see if they have new murmurs or ankle swelling. And so if any of their hemodynamics are off, that's obviously a clue that maybe we need to be investigating further. Patients may also experience some chest pain, some shortness of breath, some lightheadedness. They may get ankle swelling or difficulty lying flat. And all those things would be an indication for us to investigate sooner so that we could, figure out the right modality to assess the patients.
Now, you mentioned radiation therapy. Dr. Wollman, there are many different types of radiation therapy. What kinds of radiation cause injury to the heart?
Thanks a lot. Yeah, there are a lot of different types of radiation. And the way we actually first found out that radiation could harm the heart was, believe it or not, from Hiroshima and Nagasaki, and also later from Chernobyl, although by the time Chernobyl happened, we already did know that radiation could affect the heart. But after Hiroshima and Nagasaki, that was the first time we ever found out that radiation could affect the heart, because there were quite a lot more cases of cardiovascular disease about 5 to 20 years after Hiroshima and Nagasaki. Later, we learned that therapeutic radiation, which is the type of high dose radiation that we use to treat cancer, could affect the heart, mostly from treating kids with Hodgkin's disease, but also to a lesser extent from treating women with breast cancer with much, much older techniques than we use today. So once we knew from Hiroshima and Nagasaki that it could damage the heart, and then from these clinical cohorts of patients that many years later, as Dr. Weinberg said, radiation effects typically take many, many years later till you actually see them. We found out that the type of radiation we use in therapeutic oncology could affect the heart. And I really want to underscore therapeutic oncology or therapeutic radiation, because CAT scans and PET scans and all other types of nuclear diagnostic scans or X-ray scans do not cause heart disease that we're talking about today. Dr. Weinberg may want to add something else. But I'm not aware of any of those lower doses types of radiation causing heart disease.
Yeah, I understood that most of the effects are delayed. Are there any circumstances where relatively acutely, soon after treatment, people develop heart problems?
From radiation, there are some where you're treating a huge part of the heart. Usually this is for lung cancer or some other big cancer in the chest, where you can cause pericarditis. So this is not coronary artery disease. It's not cardiomyopathy. It's an acute pericarditis that can be caused acutely from radiation. But that's pretty much the only one that could happen in the short term from radiation.
Dr. Nishikubo, you mentioned that people with pre-existing heart problems may be at higher risk. Can these patients be treated safely? How do you avoid the problems in those patients?
Yeah, in general, yes. Even people with underlying coronary disease, even some patients who have underlying congestive heart failure and those types of cardiac issues, they can be treated safely. Often we can kind of tailor their treatments a little bit if we're to avoid certain types of chemotherapy that would be more toxic for them. We would try to avoid treatments that can affect the contractility of the heart that Dr. Weinberg was alluding to. I think that the other thing that we would want to do is we also, in follow-up to Dr. Weinberg's comments, we also would monitor them very closely with serial echocardiograms or serial exams, things like that. I think the other key is to make sure that we address and that we control what we can control. In other words, pay attention to the blood pressure issues, pay attention to the cholesterol issues, and try to keep those factors under control during their treatment, and that also helps to decrease the toxicity.
Treating the whole person, not just the cancer.
Absolutely.
Yeah. Dr. Weinberg, you mentioned the diagnostic tests that you use to follow patients or perhaps evaluate patients with symptoms. Can you talk a little bit more about what kind of tests, what kind of imaging you use to evaluate the heart in these patients?
Yes, absolutely. Well, one of the easiest things that we use to evaluate the heart is an echocardiogram. It's kind of right at our fingertips. We have them in the office and at the hospital, and it's just a real quick, easy way to get an assessment of the heart function. So that contractility or the squeeze of the heart that we worry about most, as it has to do with the volume of blood going through the system, can be really easily assessed with the echocardiogram. And so we're just putting a little jelly on the probe and checking the heart, and that can be done very quickly just to make sure that everything is okay. That looks at the squeeze, that looks at the valves, and it also can check pressures inside the heart. That is something that is really helpful when the patient is having symptoms. But if the patient isn't having symptoms yet, or they're having some vague symptoms and it's somewhat unclear what's going on, there are other modalities within echo that we can utilize that are not as rudimentary as just checking the squeeze of the heart and whether the valves are leaking. Sometimes we check modalities such as strain rate and imaging that has to do with looking at the hearts on a more cellular level. That is standard of care in our office, as well as the hospital. And it's something that our oncology colleagues look to us to be able to say, are these patients having a drop in their strain rate? Is this reflective of higher therapies that I've been using, or something concerning in terms of symptomatology that may not necessarily be clear and overt cardiovascular symptoms?
Now, you, as one of the symptoms, and this is commonly known, you mentioned chest pain. What are the things that might cause chest pain in addition to heart problems in cancer patients?
Well, so obviously one of the things that we worry about the most is that there could be a blockage in an artery. And you can have a blockage in an artery from a variety of different things. The stuff that I generally see classically is build up slowly over time, but sometimes in cancer patients, you can end up seeing little clots that could come into the artery. And so that would be something that we would be looking for. Dr. Wollman reported earlier that we also pay attention to the sac around the heart. So the pericardium can become inflamed. There can be fluid that builds up in there. So that can cause some chest symptoms as well. Additionally, when you have extra volume in your system and your body is processing some of this extra fluid, you can end up with congestive heart failure or elevated pulmonary artery pressures. Those things can also cause a pain syndrome within the heart. So we look for all of those different things when we're assessing patients that have chest pain.
Dr. Nishikubo, are there other sources of chest pain in patients receiving cancer therapy that they should be aware of? Do they have to be greatly alarmed that it's a sign of a serious heart problem if they have chest pain?
It's, obviously there are other things besides cardiac issues that can cause chest pain. The one cardiac side effect of some of the chemotherapy medications that we use that I would add to Dr. Weinberg's list is also there's a rare, some types of chemotherapy and some of the newer immune types of chemotherapy can cause a myositis, which is an inflammation actually of the heart muscle. And that can cause chest pain. Some non-cardiac causes of chest pain would be blood clots in the lungs, so pulmonary emboli. And oftentimes people with cancer are at a little bit of a higher risk for forming blood clots. So that's always something that we have to keep in the back of our minds. Usually that chest pain is pleuritic. In other words, it's worse if you take a deep breath. So there are certain characteristics of that sort of pain that are different than what we associated with cardiac chest pain. The other thing that can cause chest pain that is due to myocardial, due to an effect on the heart, but it kind of indirectly is, most of our chemotherapy medications can cause anemia. And being anemic, having a lower hemoglobin can also put some strain on the heart. So even if somebody doesn't have underlying heart disease, they can start feeling, shortness of breath and some of the other symptoms that Dr. Weinberg was alluding to.
Good. In the scope of complications that can occur during cancer therapy, how high on the list is cardiac complications? Is it the most common thing, or are there other things that are more common?
So I can start to answer that, and Dr. Wollman and Dr. Weinberg can chime in as well. I think that direct cardiac complications of the chemotherapy are relatively uncommon compared to some of the other things that we see. But again, a lot of the side effects that we see indirectly will affect heart. The most common being anemia, as I mentioned before. That's an extremely common complication of most of our chemotherapy medications. And so that will affect the heart function. There are a lot of the chemotherapy medications that can cause increased risk of blood clots and that sort of thing. And that can affect also cardiac function if it causes a pulmonary embolism. There are a lot of our chemotherapy medicines also can cause arrhythmias or irregularities in the heart rhythm. And that's affected by other medications that somebody may be taking simultaneously. So I think that direct effects on the heart are relatively uncommon in the grand scope of things, but a lot of the other side effects of chemotherapy and some of the newer immunotherapies indirectly will affect heart function.
Yeah. Dr. Wollman, how big a worry is heart damage in radiation therapy patients? Which ones are at risk, and when do you really see these problems?
So it's very dependent on the type of cancer that you're treating, and particularly, and I think I mentioned this earlier, younger people with Hodgkin's disease or other lymphomas are by far and away the most common patients that many years later will go on to get heart disease from their radiation treatment. One of the little things none of us like to think about is when beyond the age of 20, most of our cells aren't growing and becoming more cells. Most of our cells are dying as we get older. And it's really young kids that radiation can affect heart many, many years later. To a lesser extent, with technologies that are about 20 years old, breast cancer, there was a very small increase in heart disease in women who got radiated to left-sided breast cancers than right-sided breast cancers when you go back to the 70s and 80s, when we first started doing a lot of radiation for breast cancer. We don't think that really happens these days with good technology. So it really depends if you're treating an area of the body that's close to the heart, and if it's a young patient, you worry a lot about it and you do everything you can to prevent it.
Yeah. So a combination between the age of the patient and the area that is specifically in the beam of the radiation therapy, that's really establishes the risk.
Right.
Dr. Weinberg, if somebody has problems, cardiac problems during or after cancer therapy, is this invariably permanent damage, or can it be something that can resolve spontaneously, or something that can be eliminated with therapy?
It looks like Dr. Weinberg is
Yeah,
not
Dr.
on at this moment, but I believe that she's working on getting being put back on. So if maybe we could go to the next question and then we could ask that of her when she comes back on. Thank you.
Okay. Dr. Wollman, you were talking about the risk factors for cardiac injury. What modifications have been done with newer forms of therapy, radiation therapy? We've seen quite an evolution in the technology over the course of my career. What newer techniques can be used to minimize risk of heart?
Sure. First of all, avoiding radiation is the best technique. And for the disease that I mentioned earlier, lymphoma, i.e. Hodgkin's disease, we have changed the way we do treat a lot of patients with Hodgkin's disease. When Hodgkin's disease was first conquered in the 50s and 60s, radiation was all we had. And because Hodgkin's disease can go in the neck and the middle of the chest and the armpits, the radiation blasted the chest and blasted the heart. And as I said earlier, that's many years later, we found out that was a really bad way to do it. Well, then along came some really good drugs, and we found out we could turn down the radiation or eliminate it completely, and that would totally decrease the amount of heart disease. And I think, Nina, if you could bring up my first slide, I could show you what I mean.
Right.
So let me just see. My picture went away, but I'll get it back. Okay, so Hodgkin's disease radiation, if you look, A and C are virtually the same, but B and D, you could see the area in red. So if you look at A, we were hitting a huge amount of the heart with the old type of radiation. And particularly we're hitting where the coronary arteries take off and go to supply the heart with a lot of blood. So we were causing a lot of blockages in the heart in A and B. But if you go down to D, there's almost no radiation hitting the heart. And D is the kind of radiation we do these days. We use much smaller, tighter targeted radiation fields and avoid the heart. And we also use lower doses. And then, as I said, we occasionally don't use radiation at all. And so I think there's much, much less heart disease with radiation these days for Hodgkin's disease. I know there is. And with breast cancer, if you could show the second slide. We use something called breath hold radiation when patients are getting treated to the left side of the chest. So if you see what the radiation beam in these two slides, the slide on the left, standard radiation treatment, is without the patient holding their breath. And you could see when the patient holds their breath, and most people can hold their breath for about 20 seconds, which is all we need to give instead of one zap. Most people hold their breath for 20 seconds and breathe, then hold their breath for 20 seconds and breathe. And then we get a minute of radiation in with people holding their breath. That's all you need to totally miss the heart. So breath hold for breast cancer on the left is a big, huge advance in doing exactly what you asked, Dr. Martin.
Mm-hmm. Now, in neurosurgery, we're using a variety of different techniques to be highly precise, rotational administration of radiation therapy, stereotactic or image-guided therapy. Is that generally used in techniques, perhaps for the lung or breast to avoid the heart?
Yes, definitely. We use those quite a bit for Hodgkin's disease because it's a lower dose. So breast cancer radiation, just to use numbers, is about 6,000 rads of radiation, whereas Hodgkin's disease these days is about 2,000 rads of radiation. Those techniques you're thinking of, they really concentrate high dose. They don't do that much with low dose. So some of the things you're familiar with in neurology, where we're using much higher doses, we don't use those techniques as much for Hodgkin's disease. It's much better to have a lower dose and a tighter field than super concentrating the dose with things like SBRT and IMRT. But for breast cancer, we sometimes do use those techniques because that's more like the 6,000 rads of radiation that's necessary. But we do use whatever we can to squeeze the dose out as much as we can.
Right. The Dr. Nishikubo, are there additional therapies added to the cancer therapy to avoid cardiac complications or to protect the heart from the potential effects of the cancer-related treatment?
Yeah, there have been a number of agents that have been looked at for that. You know, I would say that back in gosh, the 1990s, I guess it was. We were looking at things like amifostine and some other medications that we thought might be helpful. Nothing that we can add can really seems to really significantly change that. But again, what we can do and what we do is we will monitor the heart function very closely and make adjustments during the treatment. So whether it be to just hold the medication, you were asking before, are these changes reversible? And in some cases they are, especially if you catch them early and make adjustments early. Then you can either avoid, even just holding the medication for a few doses often lets the heart tissue recover. And then oftentimes you can actually use some of the medicines, you can actually use the same medication on an ongoing basis. It's for in terms of adding another medication that will help protect the heart, we haven't been really as successful in that, but again, making adjustments by watching how somebody is doing very closely, you can often avoid kind of the long-term effects.
This may be a little hyper technical, Carol, but I know we were all concerned when these new drugs for HER2 new breast cancer, which is a smaller subset of breast cancer, were coming out that they had some cardiac effects, and we were very worried in radiation because we give the drugs at the same time as the radiation, whether that would increase the risk of cardiovascular effects. But it seems like that hasn't turned out to be as much of a problem as what we worried about.
Well, I think that again, that's one example actually of a drug where you can, if you notice that the ejection fraction that Dr. Weinberg was alluding to, if you notice that that's falling, then we can hold the medication for a while and restart. With Herceptin and the anti-HER2 drugs, yes, when you combine those medicines with something else that can affect cardiac function, it seems like that has a much greater effect on the contractility. So for instance, we don't use Herceptin with the anthracycline, so like adriamycin and those sorts of medications. We wait until after that drug is, we finish using the adriamycin, if you will, before we would add in the Herceptin. Same sort of thing that you're asking, Dr. Wollman, in terms of there are certain drugs that we would not combine with radiation just because the effects then will be multiplied. And so again, that just shows that you have to look, as you were saying, Dr. Martin, you have to look at the whole person and take into account everything that's going on with that person and all the other medications that they're taking.
So, Dr. Wollman, it's clear that lung and breast cancers are going to be in close proximity to the heart and potentially at risk. Are there other kinds of cancers where you really worry about this? What about esophageal cancer?
Yeah, stomach is kind of sneaky. Stomach cancer, people think, oh, stomach, heart, not that close. But they're pretty close. And when we treat the stomach for cancer, you actually do treat a fair amount of the lower portion of the heart, which doesn't affect the takeoff of the coronary arteries, but may affect later cardiomyopathies. Unfortunately, stomach cancer is a really brutal cancer, and people don't tend to think of it like we do about Hodgkin's disease and breast cancer as associated with radiation, but people who are lucky enough to survive such a bad cancer and live a long time, I think there are a lot of cardiac issues. And esophagus cancer is another one that for many years we did terribly. We didn't cure very many people, so they probably didn't live long enough to see the cardiovascular effects. But now that patients are living a lot longer due to better radiation, better drug therapy, better surgery, and immunotherapy, I think it's going to become more of an issue for us to deal with as we conquer these cancers. So yeah, anything that's in the chest, lung cancer, esophagus cancer, and stomach cancer, which is sort of in the chest, can affect the heart.
It looks like Dr. Weinberg's back.
I'm so sorry.
That's quite all right.
I have a few people in here, which is why I have a mask on.
Okay, that's quite all right. You know, we were talking a little bit about whether or not the cardiac complications that might occur, are they reversible? Are they treatable? Or are they invariably progressive and established?
So the treatments for when we finally diagnose somebody with some difficulty with their heart muscle after having cancer therapy is, if we can get there in the real early stages and the therapies can be dialed back, sometimes we add different medications that can help improve the squeeze of the heart. And those are things that are, I believe, why our oncology colleagues are so on top of our patients, such that we do very regular checks and they have a lot of exams. If you can get there kind of early in the stage and be able to tailor therapies accordingly, oftentimes the effects can be reversible. That's a lot of for the more acute changes that are going on relating to the pump problems, the squeeze problems of the heart or fluid buildup. Some of the longer term changes that occur in the heart muscle 10 and 15 years down the road may be a little bit more precarious to take care of. But there are other therapies and procedures that we do to follow along with patients, and we treat them similarly to our patients that have those disease processes from other things that are not necessarily cancer related, like blocked heart arteries, arrhythmia issues, valvular heart disease.
So we hear a lot about therapies to protect the heart in patients in general. Diet, exercise, supplements, omega-3 fatty acids, there's quite a list. Are any of these of any use in protecting the heart during cancer treatment?
So from my perspective, it's a great question. I am not aware of any data that supports that. Most of the data that supports patients that are having difficulty from a cardiovascular perspective affecting their heart usually go on standard therapies that we know will improve the squeeze of the heart, like ACE inhibitors, angiotensin receptor blockers, beta blockers. Those are medications that we classically use for patients that have cardiac dysfunction. And they have lots of evidence that shows that those medications can improve the squeeze of the heart and help if their patients end up with extra fluid in their system. Things like diuretic therapies and Lasix or other medications that we may use for those conditions.
So Dr. Nishikubo, we're learning about the stress that the heart experiences potentially in the treatment of cancer. Does this impact the kind of activity the patients with cancer can participate in? Can they exercise? Can they work out? Can they run a marathon?
It's actually funny you ask that. Actually, I've had a couple of people who were on active chemotherapy who actually ran the LA Marathon. They're they're my heroes, actually. But no, in general, I think, I encourage my patients to be as active as they possibly can. I kind of liken it to when you have a bad, if you've ever had influenza or had the flu or a bad viral infection, if you stay in bed the whole time, you are going to be much weaker coming out on the other end than if you were up and around and, it maintains some sort of activity in terms of your muscle tone, in terms of, your energy level. The recovery period is just going to be much, much shorter. So I actually encourage people to exercise, to keep up some activity during their treatments. I do warn them that if they get tired, they should definitely stop and rest. Don't try to push through when they start getting tired. But I think the more active people can be, the better. Obviously, if their counts are affected, if they're very, very anemic, I'm not going to want them to add that extra strain. So it's, but if they're maintaining their hemoglobin in a reasonable range, then I like my patients to be very active.
So there's a lot of excitement around the new class of drugs, the immuno-oncology drugs, the drugs that impact the immune system and enhance the immune system's ability to fight cancer. Do these new drugs have any effect on the heart?
Yeah, they can. Again, they affect them in a little bit of a different way than the standard, the older chemotherapy agents did. So a lot the older chemotherapy medications affected more the contractility, the squeeze of the heart that Dr. Weinberg was alluding to. The immunotherapies, actually, what we found is they can cause, they do stimulate the immune system. So they can cause an inflammation, which is the myocarditis that we can see rarely, but it is a known complication of some of the immunotherapies. I think with other classes of the new treatments that we have, I think we're seeing a lot more effect on the conductivity. In other words, causing more of a problem with the rhythm of the heart. Some of the newer medicines can increase the risk of things like atrial fibrillation and those sorts of complications. I think that yes, they do still have effects on the heart, although they're a little bit different than some of the older agents that we use.
So Dr. Weinberg, there's a lot of innovative new therapies for heart problems, from coronary artery stenting to minimally invasive valvular replacement. Do any of these new developments play any role in the treatment of the kind of heart problems we see in cancer?
So that's a great question, and I think cardiology is so interesting because it is being heavily researched, and there's lots of new modalities that are coming out all the time. There are a bunch of new drugs that have come out over the past year that we have been utilizing a lot for our patients that have heart squeeze problems. Medications such as Entresto are really big now. They seem to help with the the squeeze of the heart, improvement in getting some of the fluid off. So those are really great drugs that we have been utilizing. As it relates to procedural therapy, some of the percutaneous approaches, so those are the procedures where we go in through an artery or vein peripherally and thread wires and catheters up to the heart in an effort to fix valves, close holes, monitor for extra pressure without actually cutting our patients in their chest wall. Those are really wonderful new techniques and therapies that we're using here at St. John's to help our patients that have these issues, and particularly patients that have been through lots of these cancer therapies. Do appreciate going into something where they're not going to have some of the wound healing issues in the same way, and or they won't have to have surgeons cut through lots of chest wall calcifications and adhesions that may have come from the different therapies, including some radiation therapy. So I think it's really a fabulous area to be able to treat our patients with some of these new techniques. And be close to a cancer center so that we can help all of our patients.
One of the exciting advances, particularly at St. John's, is the use of so-called fluid biopsies, which means taking a blood sample and looking at DNA and RNA to interpret what's going on throughout the body, to detect cancer at an early stage, to see if cancers are responding appropriately to treatment. Are there any advanced diagnostics like this that help us detect cardiac problems at an early stage, at a pre-symptomatic stage, before there's actual established damage?
So one of the things that we do that we look at on echocardiogram is some of the relaxation principles associated with the heart. So even before you have a squeeze problem, you oftentimes have a relaxation problem. And sometimes those go unnoticed because patients don't necessarily feel symptoms associated with that. So those are some things that we look at on echocardiogram. Additionally, as it relates to heart arteries, we do certain imaging, CAT scan imaging to the heart to look to see if there's any buildup of plaque and things like that before it actually becomes a problem. And some of those technologies can tell us about the valves, the aorta, a lot of different things that can be affected by the radiation therapies. Those are some of the things that we utilize. As it relates to blood work, there are some blood tests that we use for anybody that has volume overload situations. Things like BNP or N-terminal pro-BNP. Those are tests that we look for in the blood to look to see if there could be a problem. Oftentimes they're starting to elevate around the time the patients have symptoms.
There's so much interest in genomics now, Dr. Nishikubu. We're finding out that certain genetic abnormalities predispose a person to certain types of cancer. Are there any known genetic abnormalities that increase the risk of cardiac abnormalities in the course of treatment of cancer?
Yeah, that would be great if we could identify a subset of people who are at a higher risk. Not with what we know right now. Again, I think that what we know are risk factors are underlying congestive heart failure. So somebody who has already has an underlying problem with how much their hearts is able to pump the blood through the system. An underlying coronary artery disease or an underlying arrhythmia. I think those are the only things that we know of right now that predispose.
Well, Dr. Ora Gordon, who's in our Cancer Institute, is launching a large genomic study to identify the predictors of various types of disease and to predict what kind of complications might occur with different drugs, how drugs will affect individual patients. So maybe she'll come up with some answers for us in the next couple of years as she expands this research study. Well, let's take a look at any questions that may have been coming in from our audience. And let me take a look at a couple of these. So one individual asks, I recently underwent radiation therapy under the care of Dr. Chaikin for biochemical recurrence of prostate cancer. The area of therapy was a prostate bed and lymph nodes. What are my levels of risk for heart issues related to this kind of radiation therapy, Dr. Wollman?
No worry whatsoever from the radiation. Like some of the drugs that are also used, so if hormonal therapy is given at the same time as radiation, which is very common for some types of prostate cancer, some of those drugs have a small chance of causing cardiac effects, but the radiation itself for prostate cancer would not cause any risk unless my therapists were terribly inaccurate at targeting the prostate. That's a
So
joke.
a little clarification, please, Dr. Weinberg. What does squeeze of the heart mean?
So on our reports, what we're generally looking at is the ejection fraction. So we look at the 4 chambers of the heart, and the left ventricle is the chamber that squeezes blood through the body. So it's generally the thickest, it's the most powerful. And so if the squeeze of the heart is impaired, so the ejection fraction is low, you can end up with a backup of fluid. You can end up with congestive heart failure or cardiomyopathy. So those are the classic things that we're looking for as kind of the big bad stuff on echocardiograph.
Okay. Another one, maybe Dr. Nishikubo, for you. As a 36-year-old stage 3 breast cancer survivor who just finished IV chemotherapy a year and a half ago and radiation therapy a year ago with no previous heart conditions, how cautious should I be of what I eat affecting the heart going forward? Is a cup or 2 of coffee or tea a good or a bad idea?
Yeah, so I think, again, this speaks to making sure that we, address any other underlying conditions that might contribute to heart disease. So, keeping the blood pressure under good control, keeping the cholesterol under good control. Diet-wise, we usually recommend just a low-fat diet, both in terms of, risk, decreasing the risk of having a recurrence of the breast cancer itself, and then also just in terms of heart health. The cup of coffee or tea, it's it's an ongoing controversy in terms of how much effect caffeine and coffee has. You know, I kind of joke with my patients. It depends on what year it is, kind of whether coffee is in vogue or out of vogue in terms of risks. You know, but I think the key is to make sure that that you that one stays hydrated. You know, again, optimizes the lipid control and the blood pressure control. So, you know, I don't think 1 or 2 cups of coffee or tea are going to have a great effect in terms of a negative effect on the heart. So, you know, I don't think that should be an issue. But just maintaining a healthy diet and a healthy lifestyle, I think, is what's going to help the most.
Terrific. Well, that hits the questions that we've gotten so far.
Dr. Martin, I do see a couple more that I could ask real quickly. What are the cardiac effects from aromatase inhibitors?
Yeah, so the aromatase inhibitors, they don't commonly directly affect the heart tissue. Again, indirect effects that they can have. There has been some concern with some of the aromatase inhibitors that they can affect the cholesterol levels and lipid levels. So again, be important to monitor that for somebody who's on an aromatase inhibitor. But in terms of direct cardiac effects, that would not be a common side effect of those medications.
Okay, great. Thank you. And Dr. Wollman, when you're talking about old therapies, how far back are you referencing?
Well, I assume that had to do with breast cancer. So, you know, probably, you know, over anything that's 20, and within the last 20 years, people have been using a lot of technology to decrease the risk of heart disease. Breath hold for left-sided breast cancer is something most people have been using for the last 5 years. So if it's within the last 5 years or so, that's pretty modern, but within the last 20 years or so is fairly modern as well.
Okay, great. Thank you. And then a question that just came in. What about the drug Darzalex? Will this affect the heart?
You know, again, I think that not so much a direct effect, but indirect effects definitely. So you know, I think it just again keeping a kind of keeping an eye on all the aspects in terms of blood pressure and any new symptoms that somebody is having and things like that. That's going to be the most helpful.
Great, thank you. Well, it sounds like we have gotten through all of our questions now, and I just want to say thank you so much to all of the panelists. You know, we haven't really spoken about, we've spoken about specific cancers and how, you know, the research is going and care for that. We haven't really talked about some of these multi-symptom situations. So like, how does it affect the heart and how is it affecting the brain? So we're going to be doing more of that this year. And, you know, this was really interesting and helpful. And we've had a lot of questions through, you know, the last year doing our webinars about cardiac effects of cancer treatment. So, you know, thank you very much to our speakers, you know, for giving your time today and the fantastic questions, Dr. Martin, you had, you know, to the speakers. So thank you. That's wonderful. We have more webinars this year that we'll be doing one a month. And so in March, we're going to be talking about colon cancer and really about the rise in diagnosis for younger people. So take a look, keep a lookout for an invitation for that. In April, we'll be speaking about cancer treatment and cognition and with our brain health team. So again, you know, looking at multi-systems here and how is your cancer treatment affecting your brain cognition? I know we'll have a lot of people interested in that webinar. And in May, we're going to be talking about new research and treatment in brain cancer. So we've got an amazing brain cancer team here at St. John's Cancer Institute and St. John's Health Center and the Pacific Neuroscience Institute. The three together make up like an incredible brain health team that we are very well known for. So that will be in May. If you have any additional questions, please don't hesitate to email us. Just reply to any of the emails we've sent to you, and we'll get back to you with your answers. And I think that's it for today. We're done a few minutes early. I'm sorry about our technical difficulties, but Dr. Weinberg, way to go. Way to make that happen and get back on. So we appreciate that.
I'm sorry.
No problem at all.
Thanks for all
Thank
the good insights. Very much appreciated. Thanks to those who sent in questions, Lynn Brewer and Stanley Schloss and Joan Chodorow and Jessica Valle and Susie Shapiro. Thank you for your questions. Michelle Nadalin. So we look forward to seeing you again when we have our next seminar, and feel free to let us know if there are additional topics of great interest to you, and we'll put them in the line. Thank you.